As we all know, that rheumatoid arthritis is a systemic disorder which is characterized by chronic inflammatory polyarthritis of unknown etiology. It also involves the skin, eyes, lungs, and the blood vessels. The course of rheumatoid arthritis is fluctuating and it has a very unpredictable prognosis. There is also increased risk of CVD related deaths with this. The pathogenesis is complex and multifactorial. In brief, the rheumatoid arthritis pathophysiology involves the release of inflammatory cytokines from macrophages. These cytokines are released when the macrophages are presented with T cells and antigen presenting cells. These inflammatory cytokines, TNF alpha and interleukin 1, it leads to synovitis, production of collagenase leading to destruction of extracellular matrix, release of matrix metalloproteins which leads to cartilage degradation. In osteoarthritis, there is a role of tumor necrosis factor alpha and interleukin, but apart from that, there seem to be increased levels of interleukin 6, interleukin 17, and metalloproteins have also been implicated in this. I will present a small video on the pathophysiology.
The pathologic hallmarks of rheumatoid arthritis include inflammation of the joints, particularly the small joints in the hands, wrists, and feet, accompanied by cartilage destruction and bone erosion. Underlying inflammation leads to many of the characteristic signs and symptoms of RA, such as pain and swelling of the joints. Inflammation results from abnormal propagation and activation of many types of immune cells, resulting in the secretion of cytokines and other mediators that sustain and amplify the inflammatory environment. As a key pro-inflammatory cytokine, TNF-alpha, along with other cytokines, activate immune cells, including macrophages, as well as other cells such as synovial fibroblasts. In a key step, activated macrophages and synovial fibroblasts release pro-inflammatory cytokines, including TNF-alpha, IL-1 and IL-6, and mediators of vascular growth, including VEGF. VEGF is essential to the process of blood vessel proliferation, or angiogenesis, which facilitates an influx of activated cells. These cells contribute to the growth of pannus and sustain the inflammatory cycle. The growing, vascularized pannus develops villous projections that result in better access to the cartilage and bone, and therefore greater opportunity for the activated cells to release damaging inflammatory mediators and enzymes. In the interface between pannus and cartilage, activated synovial fibroblasts and macrophages are a source of enzymes that degrade the cartilage matrix. These include MMPs or matrix metalloproteinases. Thus, however, in response to stimulation by TNF-alpha, IL-1, and other inflammatory mediators, chondrocytes become activated in the rheumatoid joint. Activated chondrocytes secrete more inflammatory factors and more metalloproteinases, MMPs, which aggravates inflammation and cartilage damage. The cumulative result is irreversible cartilage damage and joint space narrowing. Under normal conditions, bone remodeling involves a tightly regulated balance between bone resorption and bone formation. However, excessive TNF-alpha helps stimulate osteoclastogenesis and bone destruction. In the marrow, TNF-alpha helps stimulate monocyte differentiation into osteoclast precursors. At inflamed joints, in the presence of macrophage colony stimulating factor, TNF-alpha, and rank ligand, osteoclast precursors differentiate into mature osteoclasts, resulting in bone resorption. Thus, the direct and
So it is proven without above doubt that TNF alpha and interleukin 1 are the main cytokines which are involved in rheumatoid arthritis and even in osteoarthritis. So let's go a step beyond that. These tumor necrosis factor alpha and interleukin 1 are controlled by nuclear factor kappa B, which is present in the cytoplasm of the cells. It is a transcription factor present in all the cells, and it plays a role in the inflammatory and immune response. It acts as a master switch to switch on or switch off the inflammatory process. The disorders due to activations are RA, rheumatoid arthritis, ankylosing spondylitis, osteoarthritis, psoriatic arthritis, or juvenile rheumatoid arthritis. Let's go down to the process how nuclear factor kappa B activates the activates the inflammatory process. The inflammatory stimuli by antigen by macrophages such as TNF alpha and interleukin will enter into the cell. This is the cell membrane. It acts on the IKB kinase, which causes the inactive nuclear factor kappa B to become an active nuclear factor kappa B. Now this activation of nuclear factor kappa B goes into the nucleus, acting on the RNA and DNA, causes the nucleus to produce proteins which are the inflammatory mediators such as TNF alpha 1, TNF alpha, interleukin 1, interleukin 6, COX2 and inducible nitric oxide synthase. Now these inflammatory mediators act on the synovial membrane, causing inflammation and proliferation, causing of pannus formation. It acts on the chondrocytes, causing cartilage destruction, and acts on the bone, increases the osteoclastogenesis and bony erosion. Cadila Pharma has introduced a new option for management of osteoarthritis, that is curcumin. Curcumin is an active phytochemical compound which is obtained from rhizomes of Curcuma longa. It has anti-inflammatory, antioxidant, anti-proliferative and anti-angiogenic properties. It acts as a master switch for inflammation. Since you inhibit the NF kappa B, therefore the production of tumor necrosis factor alpha and interleukin 6 is decreased, thereby decreasing the inflammation. The sites of actions are: it prevents the IKB kinase, thereby preventing the formation of active nuclear factor kappa B. It acts the migration of active nuclear NFKB into the nucleus, and thereby it prevents the formation of inflammatory mediators. Now evidence, we have literature which says that there is a great improvement in the DAS score and ACR score as compared to plain diclofenac. This was a study done with 45 patients divided into 3 groups, including curcumin, curcumin with diclofenac, and curcumin just plain diclofenac. As you can see, the ACR scores are decreased in curcumin with diclofenac. The DAS scores also, as you see, with plain curcumin, the baseline scores have come down to 3.5 as compared to plain diclofenac, which is 3.89. In a pilot study, 18 patients of RA were treated with curcumin for 2 weeks. The end result was curcumin decreased the joint swelling, the morning stiffness, and increased the walking time of the patient. The curcumin is also has a good GI tolerability. In another experience with curcumin, 820 osteoarthritic patients were treated with curcumin for 6 months. There was significant improvement in pain as shown in the graph. By decrease in the visual analog scale, the pain scale has decreased, improved in the joint flexibility, and better quality of life. 50% of the patients were able to discontinue NSAIDs and analgesics. In another study, 367 primary osteoarthritic patients with a pain score of greater than 5 were randomized with Brufen and curcumin, and the treatment was given for 4 weeks. As you can see, at the end of 4 weeks, the WOMAC scores between the patient who are treated with Brufen and the patient who are treated with curcumin comes down to the same level. with the added advantage of better GI tolerability than ibuprofen. In 100 patients of OA were treated with curcumin for 8 months. This significantly decreased the serum inflammatory biomarkers such as INL1, interleukin 6, soluble vascular cell adhesion molecule 1 and ESR. There were greater than 50% decrease in the WOMAC score and 3-fold increase in the treadmill walking distance. The patients already on NSAIDs and analgesics, co-administration of curcumin caused a decrease in the need for NSAID and decrease in the GI side effects associated with NSAIDs. In combination of curcumin with diclofenac, study was done. 88 patients were treated either alone with diclofenac or with curcumin. It was found that in a combination therapy, the doses of diclofenac was reduced and the pain relief was better, and there was a better knee injury and osteoarthritis outcome scores.